Okay, I'm going to broadcast now and make you host يا أروى.
دكتور نبدأ 9 sharp صح؟
Yes.
Okay.
Dr. Arwa, can you please allow me to share my screen?
Okay, ثواني بس. معلش دكتورة بس كيف؟ وين أروح؟ Can you try now, bro? السلام عليكم ورحمة الله وبركاته. Okay. I'd like to welcome you all to the monthly scientific activity of the Oral and Maxillofacial Radiology Division of the Department of Oral Medicine and Diagnostic Sciences, King Saud University. I'm Dr. Arwa Al-Azman and will be the host for today's meeting. Before we start, I'd like to clarify that there will not be any certificates for attendance provided for this lecture. للتوضيح لن يكون هناك أي شهادات حضور لهذه المحاضرة. If anyone has any questions, please post them in the Q&A section. And now I will introduce the speaker, Professor Asma'a Al-Ekrish, who is a professor and consultant oral and maxillofacial radiologist at King Saud University. She has conducted numerous research studies on various aspects of multi-detector CT, including reconstruction techniques, dose optimization, image quality, and validation of computer hardware and image analysis software for maxillofacial applications. I would also like to welcome and introduce our panelist, Dr. Usama Al-Ghamdi, who is an assistant professor and consultant surgeon at King Saud University, specializing in oral and maxillofacial surgery and microvascular reconstruction. Now we will proceed with the lecture about basics of multi-detector CT for dentists. Prof. Asma'a. Prof. Asma'a, we cannot hear you.
Sorry about that. I was still in mute. Thank you for the introduction. Bismillah ar-Rahman ar-Rahim. Alhamdulillah wa salatu wa salam ala Rasulillah. I'm pleased to be able to talk to you all this evening about multi-detector computed tomography specifically how it relates to dental diagnostic and therapeutic tasks. However, please note that everything we say regarding the technical aspects of the modality and the image quality considerations, they are applicable to any field of healthcare. So just at the outstart, I'd like to declare that I have no conflicts of interest related to any of the software algorithms that will be discussed today or any hardware devices. Today, I will talk about first the basics of CT image production and display, then the advantages, uses, and limitations of multi-detector CT in the maxillofacial region, and then image quality considerations and dose considerations. To begin with, multi-detector CT or computed tomography in general was first presented in 1972 by Godfrey Hounsfield, who was an engineer. When developing CT devices, he used existing mathematical algorithms, which were developed by Alan Cormack, a mathematician 20 years previously. And the reason that he needed these mathematical algorithms will be presented shortly in later slides. So basically, computed tomography is a radiographic technique that blends the concept of tomography with computer synthesis of the image. What is tomography? It is taking an image of a slice of the body. So you're taking a sectional image, which would otherwise have been covered by other parts of the body. So we were able to visualize a slice. That is tomography. So computed tomography is using a computer to be able to generate that slice. The system components or the hardware components of computed tomography machines are, first of all, a gantry, which is shaped like a donut. It's a device with a hole inside. And this gantry contains the X-ray source and the detectors which receive the X-rays. We also have a motorized table upon which the patient lies down, and then this table is raised and then moves so that the patient's body goes inside the gantry for imaging. And we also have a console which contains the computer and other devices. The computer is used to control the machine, the exposure and the motion, exposure of the X-rays and the motion of the table. And we can also have other devices such as video monitors or microphones to help in communication with the patient. Now, inside the gantry, if we were to take like a cross section, if we were to cut the gantry from the top to the bottom and look inside of it, what we would see, this is on the right side, you will see the inside of this donut-shaped gantry. What you will see is you will see rows of detectors all around this donut, like all around here. And the detectors are colored green. And these are stationary. They are fixed in place all around the gantry. Then you have a rotating X-ray source, which rotates around the gantry, around the patient's head. So the X-ray source rotates around the gantry and the X-ray beams pass through the patient's head or any area of the body, which is inside the gantry, to reach the detectors on the opposing side. In order to image a certain area of the body, we use scout images or scout images. Like in our case, we use scout images of the head. We use lateral images and posterior anterior images. And then we select the region of interest. The operator then, using these green lines or any similar tool, depending on the machine, we will outline the area that we want, as well as the angulation of the images that we want. If we want them to be angulated or perpendicular to the floor, we can select the position and orientation in both, in all three planes. So for example, in the maxilla, we would have our originally acquired sectional images parallel to the maxilla here and here, whereas in the mandible, we would angulate the sections to be parallel to the mandible. Now, When acquiring one sectional image, we have our X-ray tube, and you have your row detectors on the opposing side. And then you have a fan-shaped X-ray beam exiting the X-ray tube to reach this row of detectors. And then with one rotation of the X-ray source, we will receive, or we will obtain one axial section. Then, as the table slides into the gantry, we have, as the table slides into the gantry, we have the additional rotations and additional sectional images. So once we have this one rotation, how is the sectional image produced? Well, in order to explain that, I would like to use this simple object where you have one object with uniform density, but with numerous holes inside of it. So if we were to take a sectional image of this object, what would happen is that as the X-ray beams exit the machine, the computer knows the amount of X-rays which are being emitted by the X-ray source. And then as they pass through this object, they will reach the detectors. And the amount of X-rays exiting the object to reach the detectors are also known by the computer. So now the computer knows how much X-rays was absorbed by this object along each path of the X-ray beam. And the amount of X-rays absorbed is called the attenuation, the amount of attenuation of the X-rays. So now this happens all around the object, so that all around the object, the computer knows how much X-ray attenuation occurred at all axes of the object. So the data collected by the detectors, which informs the computer about the attenuation of the X-ray beam, how much of the X-ray beam was absorbed by the tissue, is then used by the computer to try to calculate the density of this object. So now the computer has these numerical values of the attenuation factors. It then plays a very complex game of Sudoku. You've all played the game of Sudoku, where you have a grid with certain numbers placed inside, and you have to fill in the remaining numbers to make the sum of the rows and the columns add up to the numbers on the outside. So the computer is basically playing a very complex game of Sudoku in order to place the numerical values, which will explain the attenuation values all around the object. Okay. Now, this can be very time-consuming, and it's very demanding, computationally demanding by the computer. So this is where algorithms come in. The computer uses reconstruction algorithms in order to be able to determine the numbers inside each of these squares much quicker than it would be able to do so without the algorithm. And this is where the mathematical algorithms developed by Cormack come into play here. The most commonly used reconstruction algorithm is filtered back projection. This has been the most commonly used ever since computed tomography was presented in the early 1970s. Then the computer assigns gray shades to each of these numbers. And this is how the resultant image is obtained. Now, this example that I just used is extremely simplified just for clarity in order to be able to explain to you the concept. But the actual process is really much more complex. For one thing, the actual number of gray shades is not just 2, it's actually in the thousands. So the number of possible solutions to each numerical equation would be in the thousands. Also, the actual number of squares or pixels or voxels in each image is much larger. It's typically 512 by 512, or more than 262,000 pixels. So the computer needs to perform 262,000 equations simultaneously in order to be able to produce the image. However, because that is so computationally demanding, the use of algorithms allows the computer to do that in a much more efficient way. Also, the actual field of view is round, so that the X-ray beams, when they pass through the object, they are angulated relative to each other. The X-ray beam is angulated concentrically around a center of rotation, so there's a certain amount of overlap between the X-ray beams. And this overlapping of image projections may lead to some amount of blurring. And this resultant blur is overcome by the use of additional mathematical algorithms or special convolutional filters. Therefore, it can be seen that the computational requirements to produce a single CT image are very high, requiring computers with very high computational power. Now, with subsequent generations of CT machines then started adding more rows of detectors and a spiral motion of the X-ray beam, so that as the table moves, the table moves within the gantry, so the patient is moving within the gantry continuously as the X-ray source is rotating. And this effectively produces a spiral rotation of the X-ray beam around the patient. So these increasing number of detectors and the spiral rotation has led to the development of multi-detector CT scanners or spiral CT scanners or multi-slice CT scanners. Now, with these scanners, with each rotation, you have multiple image slices obtained simultaneously because you have multiple rows of detectors. In modern devices, the number of rows is commonly 64 or 128. Some machines may have up to 320 or even 640 rows. And because we now have multiple rows, which span several centimeters or tens of centimeters along the patient's body, the X-ray beam now that is emitted is cone-shaped. It's like a pyramid. Now that it's cone-shaped, similar to cone beam CT, we have increasing of scattering of the X-rays as the X-rays pass through the body. So with multi-detector CT, this scattering is reduced by the use of scatter reduction grids at the sensors. Now, each manufacturer uses different modes of scatter reduction grids. Some of them use elevated metallic grids. Some of them use depressions. So it's really proprietary. What we need just to understand is that even with this cone-shaped beam of X-ray with multi-detector CT scanners, the scattering in multi-detector CT is much less because we use a scatter reduction, or the manufacturers use scatter reduction grids. And these scatter reduction grids will absorb any X-ray beam which is not perpendicular to the sensor. In this way, only X-ray beams which are perpendicular to the sensor will actually reach the sensor, and thus we have a minimization of the scattering. Now, the amount of radiation used to produce MDCT images is affected by the product of the X-ray tube current and the rotation time, similar to any other plain X-ray or radiograph. But with a multi-detector CT, we also have something called the beam pitch. The beam pitch is the distance moved by the table during one rotation. See, when we have this spiral rotation, this distance moved in one rotation divided by the sum of the slice thicknesses. This is what the beam pitch is. So the smaller beam pitch we have, that means we have more rotations along one specific area of the body. If we have a small beam pitch. If we have a large beam pitch, that means we have less rotations. And in order to minimize helical interpolation artifacts, pitch values should be smaller than 1. Now, let me explain that. If we have a very large pitch value, which is more than 1, that means there are some areas of the body which are not being exposed to the X-rays. So what the computer will do is those areas in which there is missing information, the computer will estimate the gray density of the pixels in that area by use of interpolation, okay? So in order to avoid interpolation artifacts, we should make sure that the pitch values are smaller than 1. So we prefer to have overlapping rather than have areas of the body which are not exposed to the X-rays. Now, the general rule for maximum acceptable pitch values is seen here. So you can look at these values and compare them to the number of rows of detectors that you have in your machine. The larger the number of rows, the larger pitch value you can accept without going beyond 1. Now, there are times where we can accept a pitch value of more than 1 if we are not interested in seeing fine details, fine anatomical details. For example, in cases of full body scanning following a trauma, where we are only interested in seeing gross changes or gross abnormalities, then it would be okay to use pitch values larger than 1, because you want to just get a gross idea of the situation in the body without overexposing the patient to unnecessary radiation. However, if you need to see fine details, then you should not use a pitch value larger than 1. And in dentistry, we often need to see fine details. But in other areas of medicine, you may be able to use pitch values larger than 1. Now, another term that we need to understand is the scan field of view and the display field of view. Now, the scan field of view is usually set to cover an anatomic part. So the operator will select something like head or body. These are the terms given to the various presets of scan field of view. Now, the scan field of view will determine the area which is being exposed. And remember that the X-ray beam is passing all around the body, okay? So the entire area here, outlined by yellow, will be exposed to X-rays. However, we are only interested in the area outlined by blue. That is the area that we want to see as dentists. For example, if we wanted to see the maxilla. So then we would select our display field of view. We would limit it to the area that we are interested in. And this display field of view gives you a magnified image of part of the scan field of view. So for example, here we see an axial section of the maxilla and the airway space posterior to the maxilla. And because we now selected a display field of view, which was limited to our region of interest, we can get a more magnified view of it. Another term that we need to be familiar with is the reconstruction kernel. In addition to the reconstruction algorithms used to produce the sectional image, there are also mathematical algorithms called reconstruction kernels, which are applied to the raw data before the back projection in order to optimize the image for specific tissues. Whether we want to see soft tissues or bone tissues, we will select the appropriate reconstruction kernel to optimize it for those tissues. So a soft tissue or smooth or standard kernel enhances differentiation between gray shades. So it allows us to see the gray shades more clearly, but it produces images which are less sharp, which have margins which are less sharp. Whereas bone kernels provide sharper detail, but with the disadvantage of more noise. Because with bone imaging, we can usually tolerate more noise, but we want to see sharper detail. So these are examples of axial sections produced with these different kernels. On the left, you see an image produced with a soft tissue kernel, in which you can see the soft tissues quite clearly. You can differentiate muscle from fat, from skin. And on the right side, you can see an axial section of the mandibular condyle obtained with a bone kernel, and you can see the fine details of the trabecular bone and the compact bone. Now, this is different from viewing images in soft tissue window or bone window. These kernels are selected by the operator who is performing the Mdct examination. When we as end users, as dentists or physicians, are then looking at these images, we can then view them either in soft tissue window or bone window. So if we were to view the top image in bone window, look at how it would appear if the image was produced with a soft tissue kernel. Now, these are two different reconstructions of the same patient. One of them was obtained with a soft tissue kernel on the left, and the other with a bone kernel on the right. And they are both viewed in bone window. You can see how the image obtained with the bone kernel shows the sharper detail and higher spatial resolution than that produced by the soft tissue kernel. However, look at the images, and now please note that you can see the fine details in the image on the right, even though it was acquired with a larger voxel size. So the pixel size of this image on the right is larger than that of the image on the left. Yet we can see higher spatial resolution because, or better details, because it was acquired using a bone kernel. And how about the soft tissues? Now, again, we have the image on the right is another image viewed in the soft tissue window, but it was acquired using a bone kernel. Look at the soft tissues on the left and on the right, and you can see that there's much more noise on the right compared to the left. And the differences in the gray shades seen on the left is much more clear than those seen on the right, even though they are both viewed in soft tissue window. But because the one on the left was originally acquired, reconstructed with a soft tissue kernel, the gray shades are much more clear than those seen with the images reconstructed with a bone kernel. Okay. Now, it should be noted that with one examination, with one exposure to the X-rays, the radiology technologist, the CT technologist, can reconstruct the image twice, once using a soft tissue kernel and another time using a bone kernel, so that if we need to see soft tissues, we can look at the reconstruction done with the soft tissue kernels, and if we want to see the bones, then we can open the reconstruction done using the bone kernel. After the reconstructions are done, the computer will then stack all of the originally acquired axial sections to produce a volumetric data set. And from this volumetric data set, we can then, as end users, we can do our reformatting software to perform something called multi-planar reformatting, which is obtaining sectional images in the standard anatomic planes, the coronal, the sagittal, and the axial sections. Or we can also curve our reformatting planes to obtain corrected planes parallel and perpendicular to any object of interest. We can also obtain curvilinear reformatting because in dentistry, we are interested in the jaws, and the jaws are curved. So we can go to the jaw of interest to us. In this case, this is the mandible. And using specialized software, we can then draw We can draw a line, we can draw a curved line seen here as a orange line parallel to our jaw, and then the computer will automatically generate multiple images which are parallel to the orange line and perpendicular to the orange line throughout the length of the jaw. So these are panoramic sections obtained parallel to the line that we drew, and these are multiple transverse cross-sectional images perpendicular to the line that we drew. By increasing the thickness of any of the sections that we obtain, we can also obtain something called slabs, image slabs, or thick image sections. Now, these are image slabs which are very wide to include the entire thickness of the head posterior-anteriorly and medial-laterally, so that the resultant image now looks like a standard posterior-anterior view or lateral cephalometric view. We can also view images. When we increase the thickness of the images, we can also view them in something called maximum intensity projection to clarify certain objects. Let me explain it to you here. For example, this is a coronal section of the head here. And as you can see, these blue lines represent the reformatting lines. This vertical line represents the position of the sagittal section that you see on the right. Now, because we increase the thickness, you can see this blue area is the full thickness, or is the thickness of the sagittal section that you see on the right. Now, if we view it in the multiplanar reformatting mode, we will see all of the tissues which are included in this thickness. However, if we would like to visualize, for example, soft tissue calcifications, it is useful to use something called maximum intensity projection, whereas along the path of the X-ray beam, or along the path, excuse me, of the projection, only the voxels which have the highest value will be seen along the projection. So that if we change this mode from multiplanar reformatting to maximum intensity projection, you can now see these soft tissue calcifications or the styloid calcification much clearly. And this, like I said, it's useful for visualizing soft tissue calcifications. For example, calcifications in the parotid gland here are visualized much more clearly using maximum intensity projection. Now, I must be clear that not all software programs allow the production of maximum intensity projection images, but if your software program does allow that, it's very useful for viewing soft tissue calcifications. Now, when we are visualizing the tissues or the sections on the computer monitor, we can determine the density of these tissues in a very objective manner by measuring or by determining the CT number of the voxels or the image in the area of our region of interest. Now, the CT number of each voxel is proportional to the degree to which the material within the voxel has absorbed or attenuated the X-rays. So the more dense the material, the higher the CT number will be. So bone will have higher CT numbers than soft tissues. Now, CT numbers are also called Hounsfield units. And these numbers range from -1000, which is the number given to air, to more than +1000, which is the number assigned to cortical bone. And what we can do, we can select a region of interest, for example, in the image above, this is a transverse cross-sectional image of the maxilla. You can see this is the alveolar ridge, and this is the nasal cavity. We can select a region, and it will give us the minimum, the maximum Hounsfield units, and the average values. We can also select it by some software programs allow you to select a point or a line, and they will give you the Hounsfield units. Now, the Hounsfield units scale, you can see here on the right side, representative numbers for the different tissues. Now, please note that these numbers, the order from top to bottom will always be the same. Cortical bone will always have larger Hounsfield unit than trabecular bone, and in turn, that will have higher numbers than soft tissues. And in decreasing order, we will also see blood and cerebrospinal fluid, then fat. Fat has a Hounsfield unit lower than water, and lung has a Hounsfield unit lower than fat until we reach air. Lung, of course, because it has a lot of air vacuoles inside of it. But although the order will always be the same, the numbers which are allocated to these tissues may vary slightly depending on the exposure parameters, especially the kilovoltage used. However, the value of water will always be 0, and the value for air will always be -1000. These are standardized. For dentists, you must understand that dentine, enamel, and metallic objects have Hounsfield units much higher than 1000. And just in case anybody's interested, this is the equation that is used to determine the Hounsfield units of a particular voxel. Now, viewing these images is whether we want to see bone or soft tissue is optimized by adjusting something we call window width or window level in order to optimize the image for better visualization of bone or better visualization of soft tissues. So for example, on the left, we see CT images viewed in the bone window, where you can see the differences between the cortical and trabecular bone very clearly. You can see the details of the trabecular bone, but the soft tissues cannot be visualized very clearly. We cannot differentiate them from one another. On the right-hand image, on the other hand, we can differentiate the soft tissues clearly. We can differentiate glandular tissue from muscular tissue, from fat, from skin, but we cannot differentiate the different bone compartments from each other. How do we adjust window width and window level in order to obtain these two windows, bone window or soft tissue window? Well, the window width is the range of CT numbers which we can see. So for example, if we select a range of CT numbers of 800, this would be the window width. And the window level determines where this range of 800 numbers goes. Is it at the top of the range or at the bottom of the range? So the window level is the mid portion of the range. So for example, in this example, the window level is 600. So if I want to see bone, I will select a window level of 600 and a window width of 800. And this will give me the bone window. However, if I want to see soft tissues, I will open my window, I will go to the window level of 0, and I will open my window width to only 350 to get about approximately 100. They are not set in stone, they are quite variable. But these are just examples of the window levels and widths that can be used to obtain bone window or soft tissue window. Now, how are these images produced when we select this range and level is that the computer will only demonstrate these voxels clearly on the monitor, Any numbers above this range will appear white. Appear almost completely white because they are above the range which we opened. In order to visualize soft tissues even Dr. Arwa, can you hear me?
Yes, now we can hear you.
I believe there was some problem with the connection.
Yes.
Okay.
But now I can hear you and see the screen as well.
Okay, what was the last thing that you heard? Okay, so let me just pick up where I am right now. So in order to improve visualization of soft tissues, contrast media may be injected intravenously. Now, this contrast media has a very high Hounsfield unit number, and it goes through the bloodstream to enter the soft tissues. So tissues which have a high perfusion rate will have an uptake of this contrast media more than tissues which don't have a high perfusion rate. So it helps to visualize blood vessels and inflammation.
Prof. Asma'a, we cannot see the screen or hear your voice.
Okay. I don't know if the problem with the connection is from my side or from your side. Okay, so as you can see here, this is a soft tissue window of an axial section, and you can see the blood vessels here. The areas that I'm pointing at are the blood vessels. They can be seen clearly here because we have injected the patient with contrast media. If we did not inject the patient with contrast media, then they would not be visible. So to sum up, window width affects image contrast, window level affects image density. Now, most viewing software programs Dr. Arwa?
I'm not quite sure, what the problem is, but it keeps disconnecting.
Dr. Arwa, can you please make me as host?
Sure.
If you can transfer host functions to me, that might help solve the problem. Okay, so so you can either select presets for viewing tissues such as temporal bone, brain, lungs, liver, and these are presets which have optimized the parameters or window width and window level for viewing these specific organs. Or you can just use the mouse, and using scrolling motions of the mouse, you can play around with the window width and level, or you can actually type in set numerical values for window width and window levels. These are all options available to the end user. Now, changing the window level and window width can be done to display the air soft tissue interface in a variety of ways. When done with volumetric image, this is called thresholding. So by thresholding, we can improve visualization of the surface of the bone or the surface of the skin or even the airways. And we can even visualize both airways and bone together depending on our purposes. So the advantages, uses, and limitations of multi-detector CT in the maxillofacial region are that the advantages are that they provide images with no superimposition or blurring, no magnification or distortion, with very good contrast resolution. And because of that, the linear and density measurements acquired from CT images have very high accuracy and reliability. And we can have much clearer visual.
Prof. Asma, you are a host now, but it's still disconnecting.
Okay, so we can see clearer visualization of the internal structures and margins of anatomy and pathology. And also the images, the volumetric data acquired from CT can be imported into specialized third-party software for specialized diagnostic and therapeutic uses. For example, for specific types of analyses, even for surgical planning, and even for CAD/CAM production of surgical guides or surgical tools, or even for dynamic navigation surgeries. And in the maxillofacial region, MDCT images are very useful for visualization of impacted teeth, visualization of cysts or intraosseous tumors, or even soft tissue tumors and calcifications, evaluation of the skull in bone with in the presence of bone diseases and growth disturbances, and even to evaluate the soft tissues and the bone in cases of infections such as osteomyelitis, and also to visualize the bony compartments of the temporomandibular joint. Please note that MDCT is not useful for visualizing the disc or other soft tissues surrounding the temporomandibular joint, even if some articles may claim that it is useful, because even when viewed in the soft tissue window, we cannot see the disc clearly, even if we have injected contrast media IV. MDCT is also useful for visualizing facial trauma. As a matter of fact, for fractures or trauma of the midface, CT, whether it be multi-detector CT or cone beam CT, is the standard of care. It's also useful for evaluation of sinus disease and for evaluation of implant complications, to determine where the implant is in relation to vital structures, and even pre-implant placement, where we do implant site assessment and treatment planning. It also allows computer-guided interventions, where we can perform CAD/CAM production of surgical guides based upon the treatment planning that we did on the cone beam CT. And these images can be imported into software programs for dynamic navigation surgeries. However, MDCT does have its limitations. The diagnostic quality is adversely affected by the presence of metallic objects such as dental restorations. They may cause very severe artifacts which will obscure the anatomy or any pathology adjacent to the metallic objects. Also, the image voxels are anisotropic, meaning they are not cuboidal, they are rectangular. In the z-axis, or the craniocaudal dimension of the patient, which is the axis from the head to the feet, the size of the voxel is limited by the slice thickness of the originally acquired axial sections, so that reformatted images may end up having lower accuracy than the originally acquired axial scans in the XY dimension. And this is an example of an originally acquired axial section and the reformatted transverse cross-section obtained from this data set. You can see how the sharpness here is less than the original acquired axial section because of the large another limitation is that we cannot visualize the TMJ disc and surrounding soft tissues, and this just explains to you to try to convince you that any article that says you can see the disc is wrong. These are soft tissue images, soft tissue window images of a patient who was imaged with MDCT with contrast, and even still, we cannot visualize the disc. The reason being is that the disc and the muscles have similar density. Also, in order to visualize the images in soft tissue window, the bone becomes more enlarged because of the voxels at the margin of the bone. They tend to take the full density of the bone, and that's why you don't see the soft tissue compartments between the bony compartments as clearly as you should. Also, another limitation is that the examination is costly and not readily available. And the dose of MDCT is generally higher than that imparted by two-dimensional images and cone beam CT images. However, newer generation MDCT devices impart lower radiation doses than older devices, and some of them have similar doses to cone beam CT devices. But I would like to just qualify that the similar doses are when we are imaging the jawbones, not other areas of the body. Also, radiation doses may be lowered significantly when using MDCT if we want to view the maxillofacial osseous tissues. So that allows us to use doses similar to those imparted by cone beam CT. Now, there are certain issues that affect the image quality. The main determinants that I would like to talk about today, and which are of concern in the maxillofacial region, are contrast resolution, spatial resolution, and image artifacts. Contrast resolution, we'll start with that. It is the ability to depict subtle differences in contrast or subtle differences in gray shades. So contrast resolution improves with increased X-ray beam energy and with increased amount of X radiation or increased milliampere second and beam pitch. Because if you remember from the beginning, we said if we increase the milliampere second or increase beam pitch, that increases the amount of X radiation used. So if we increase any of these factors, we will get improved contrast resolution. And use of less radiation will lead Okay, so I'm sorry, I really don't know what's going on with the connection. Anyhow, when we have less radiation, it leads to reduction in contrast resolution because it leads to the addition of noise to the images. And if you look at the image on the left, this is acquired with a certain amount of radiation. The image on the right is acquired with approximately 1/9 the amount of radiation, and you can see it has a more grainy appearance. This grainy appearance is caused by the presence of noise. So noise degrades contrast resolution. Increased contrast resolution is not that problematic, but when we want to visualize soft tissues, it does become problematic. So high contrast resolution is a high contrast resolution is important when we need to distinguish soft tissues from each other. Look at the image on the left compared to the image on the right. The image on the right has more noise. Therefore, the area here marked by arrows is not as, the soft tissues here are not as clearly distinguishable from each other as they are in the image on the left, which has less noise. But if we look at bone, even if we have very large amounts of noise, as we see on the right side, we can still see the margins of the bone very clearly. So bony imaging does not require high contrast. So bony resolution does not require high contrast resolution, and we can use much lower amounts of doses. However, the only case in which that would not apply is when the CT images are going to be used to obtain CAD models of the bone. If we want to produce CAD models of the bone, for example, here, this is a computer-aided design model of the maxilla, then increased noise may lead to deformed models. As you can see here on the right, with much lower dose, you can see the model is very irregular. It has a lot of sharp speculations. However, how clinically significant this would be is not clear. We still need more research to determine whether this would adversely affect any therapeutic tasks which utilize these CAD models. Now, MDCT devices have automatic exposure controls, which allow the production of constant image quality while optimizing radiation dose. So we can use this auto MA to it can be adjusted to a pre-selected standard of image quality. Now, different manufacturers these presets to determine the amount of noise that you can find acceptable in your images, and then you use the auto MA setting, and the machine will then adjust the exposure parameters to make sure that you get that specific quality level always, regardless of the patient size, because as you know, patients can be either big or small, their tissues can be dense or lower, and that will lead to higher or different needs regarding the amount of X-rays. So if we select auto MA, that will produce a uniform level, uniform quality for all patients and all areas of the body. Moving on to the spatial resolution, the second determinant of image quality. Spatial resolution is the ability to distinguish fine detail or two different objects that are close to each other. Now, adequate spatial resolution is needed to detect fine osseous details or changes, or fine details in the bone. Now, spatial resolution is increased by decreased voxel size. The smaller the voxel size, the higher the spatial resolution will be. This is only one of the determinants. I will talk about additional determinants in a moment. Now, what are the things that affect the voxel size? Number one, the slice thickness and the pitch value. So if we decrease the pitch, that means we have overlapping of the spiral motion of the X-ray beam. So that decreases the effective slice thickness and we get a smaller voxel size. Also, if we increase the matrix size, the matrix is the number of pixels within one axial section. we can select the number of pixels that we want. And this is called the matrix size. So if we increase the matrix size, then the pixels will be more, hence they will be smaller, as long as we have a fixed display field of view. Also, if the matrix size is fixed, if we decrease our display field of view, we make it smaller, and the matrix size is fixed, the size of the voxel will be smaller. So matrix size and display field of view, they interact together in producing a certain voxel or pixel size in one sectional image. And this is the reason why we like to limit the display field of view to our region of interest, so that the voxels, the number of voxels can be the largest possible in that area. And as I mentioned previously, another determinant of spatial resolution is the reconstruction kernel. If we select the bone kernel, we will get higher spatial resolution compared to the soft tissue kernel. Image noise also affects spatial resolution. So large amounts of noise may degrade the overall image quality, and hence will mask tissue boundaries and reduce the spatial resolution. So for example, as you can see here, these are images of the exact same area of the patient. It's a transverse cross-sectional area of the mandible, showing the outline of the mandible and the inferior alveolar canal in the middle. This side is the buccal side, and this is the lingual side. So you can see these two images are of the exact same area. The one on the right has much higher noise. So as you can see, noise did not affect the visibility of the outer surface of the bone. So its influence on the bone interface is minimal. However, the visibility of the roof of the canal has been degraded. It has been affected. On the left side, you can see the roof of the canal much more clearer than you can see it on the right. So the noise will reduce the spatial resolution, and it is more significant when you want to see tissues or areas with high detail. But in areas where you do not need to see high detail, like the surfaces of the bone, it does not affect the spatial resolution significantly. The third determinant of image quality is artifacts. Artifacts are discrepancies between the CT numbers of an object and the true attenuation coefficient of the object, meaning the amount of the amount of X-rays that the tissue actually absorbed is not accurately reflected in the CT image. The CT numbers in the image do not reflect the actual absorption of the X-rays by the tissue. Okay, when do we have this problem? When are artifacts produced? The most common cause of artifacts, and which is of concern in dentistry, are beam hardening artifacts, streak artifacts, and partial volume averaging artifacts. So partial volume averaging artifacts are those which result when an image voxel contains more than one type of tissue. So a voxel can only have one gray shade. So if it has more than two tissues within one voxel, the gray shade that will be given to that voxel will be the average of the two. Because of that, the tissue boundaries will appear hazy or blurred, and the blurriness will increase with larger voxel sizes. So you can see the images on the left where have a voxel size of 0.3, and on the right almost 0.6, and you can see how the blurriness or haziness of the bony margins are much larger. This is caused by the partial volume averaging artifacts. Streak artifacts, on the other hand, are caused by objects with high atomic number. They can be even caused by very high density tissues. but the most severe streak artifacts are caused by amalgam and cast restorations in the teeth. They appear like light and dark lines emanating from the source object in the horizontal direction, parallel to the direction of the X-ray beam. So, knowing that they occur parallel to the X-ray beam, if we have a certain area of interest and we want to be able to see it clearly without being without having the visibility compromised by these streak artifacts, we can angulate the gantry when selecting the orientation of our axial section so that the area of interest is at a different horizontal level than the metallic restorations. So for example, if there was a tumor in the pharynx at the same level as the dental restorations, we can angulate the X-ray beam so that it does not pass through the metallic restorations and the area of the tumor simultaneously. Beam hardening artifacts, on the other hand, are those which are produced around the object. Okay, so they appear as dark areas adjacent to high density materials. Again, in the dental area, it's most often caused by amalgam and cast metal restorations. So they appear as dark areas or broad dark bands adjacent to the high density objects. So bone and tooth structure adjacent to these high density objects may appear burned out or missing. So for example, these are this is an axial section of the maxilla where we should see teeth all around. But what we have here is these cast metal restorations and covering the teeth. And because of that, now the tissues adjacent to them are burned out. We don't see any of the soft tissues or the adjacent teeth. They're completely blurred out by the beam hardening. Unfortunately, beam hardening cannot be avoided by the operator. Some authorities have advocated changing the KVP to reduce the beam hardening artifacts. However, in the presence of such high density metallic restorations, even changing the KVP will not eliminate beam hardening artifacts. Also, the usefulness of metal artifact reduction algorithms, although they have been touted in the literature, is very limited and must be used with caution to avoid introduction of inaccurate information. Because remember, artifact reduction algorithms are only estimating what the area which is influenced by the artifact. These algorithms are replacing these black and white lines by other gray shades. It is estimating what it thinks is there by evaluating the surrounding anatomy. So these algorithms are just estimating what is there. They are not giving you the true information of what is there, because once the X-ray beam has reached the detectors, khalas, that information was lost. We cannot introduce any new information which is real, related to the patient. These algorithms are only estimating. So please be careful when using artifact reduction algorithms. Personally, I prefer to not use them at all, because I don't want to use guesswork to think, am I looking at what the algorithm thought was there or what is actually there? And moving on now to dose considerations with multi-detector CT. First, I would like to mention some dose measurement terms relevant to CT examinations. First, we have our volume CT dose index, which is the amount of radiation delivered to a particular volume for a standardized phantom, taking into account scan pitch. So when what it is telling us is, using these exposure parameters and using the scan pitch that was applied, the amount of dose which has exited the machine to a particular volume of patient is this amount of dose, and it's measured in milligray. So it's a measure of radiation output, but not a direct measurement of dose absorbed by the patient. So it's useful to compare radiation output resulting from different exposure protocols or different machines. Scan length, on the other hand, is the length of the patient's body in the craniocaudal direction, or the z-axis, which is exposed to radiation, and it's measured in centimeters. The dose length product is obtained by multiplying the CT dose, the CT dose index, the volume CT dose index multiplied by the scan length. Okay, so here we have the volume CT dose index multiplied by the scan length gives us the dose length product. And this reflects the radiation output from the complete scan. So for example, we can have a volume CT dose index, which is fixed, but the dose length product for a scanning of one jaw would be different from the dose length product of scanning both jaws, for example. The effective dose, and again, the dose length product is a measure of radiation output. It's not the amount of radiation absorbed by the patient. The effective dose is the estimate of risk to an individual of developing stochastic effects or cancer induction from the examination, and it's measured in millisieverts. Now, oftentimes you will see in published papers all of these three reported. So you need to understand the differences in the terminology so you don't mix them together. What are the factors which affect those? First, like we said previously, we have our tube current, milliamperes, and exposure time, or seconds. So reduction in the milliampere is the most practical method to reduce dose. And some devices have organ-based tube current modulation, which automatically lowers the milliampere as the X-ray tube passes anterior to the body. So it reduces radiation dose to radiosensitive organs like eye lens or thyroid glands. But any reduction in the milliampere must be considered in light So you should not reduce the milliampere too much if you need high contrast resolution. Another factor which affects the pitch, the dose, is the pitch. So the higher the pitch means we have less overlapping of the spiral motion, and that means we will have less dose. And pitch values greater, but remember that pitch values greater than 1 may lead to loss of image information. So you have to keep that into consideration when determining the amount of dose. Also think about your image quality requirements. Do you want to see a lot of details? Do you want to see, if you need to see fine details, then you cannot increase the pitch. Reduce the dose by reducing the milliampere. However, like I said previously, a pitch value of 1 may be used to reduce the exposure time and dose if the examination does not require visualization of fine details. And what we have, there's another term which is the effective milliampere seconds, and that is the milliampere second divided by the pitch. So some machines, they will give you that setting, and if you reduce the effective milliampere second, that will give you a reduction in the dose. Slice thickness and matrix size are also things you need to consider with regards to dose, not because they would reduce dose per se, but rather because if we select thinner slice thickness or larger matrix size, meaning effectively if we select smaller voxel sizes, then we need to increase So if we decrease or we select a smaller voxel size through increasing matrix or decreasing slice thickness, then we must increase the dose in order to prevent the introduction of noise, okay? So because a small of voxels, we need to increase the number of, increase the dose to maintain similar noise levels. Failure to increase the dose would produce images with less contrast resolution. And again, if you need to see soft tissues, that would be a problem for you. If you need to see bone, that would not, like the surfaces of the bone, that might not be a big problem. But if you want to see fine details, that will be a problem. Another factor which affects dose is the X-ray beam, increasing beam energy, sorry. So reducing the kV to affect the dose, to reduce the dose is not recommended because there is a complex interaction between the kV and tissue contrast and image noise and radiation dose that also depends on patient size. So if you want to reduce the dose, the most predictable way to do so would be to reduce the milliampere and avoid playing around with the kV. The manufacturers can play around with the kV when they give us their preset protocols for examining different areas of the body, but we, the operators, should not play around with the kV. Other factors which affect dose is the scan length naturally. The longer the scan length, the larger the effective dose to the patient. And limiting the scan length to the region of interest is one of the most effective dose optimization measures. So only scan the areas which are needed. And also the position of the head within the gantry. If auto-MA is used, if auto-milliampere setting is used, then you must ensure that the patient's head is exactly within the center of the gantry, because if it is not appropriately centered, the amount of X-rays emitted may be automatically increased by the device to achieve a standardized image quality. And another factor which affects dose is the quality setting that I mentioned before, whether it be the noise index or the quality index. The higher quality setting you select, the more dose will be used. So you select the quality setting which is needed for the particular diagnostic task. Other factors which may Another factor which may influence the dose is the use of newer reconstruction techniques called iterative reconstruction techniques. Now, these techniques, they do not reduce the dose per se. However, they do allow the production of images with much less noise at lower doses. So they allow us to use ultra low doses and still maintain lower noise levels in the images. Now, examples of iterative reconstruction techniques used by different manufacturers are listed here in the slide, and they are proprietary to the specific manufacturers. And just to show you an example, these are CT images, transverse cross-sectional images of the mandible obtained with very low volume CT dose index. And you can see the amount of noise obtained using the traditionally or used filtered back projection, and the amount of noise seen in the images reconstructed with iterative reconstruction techniques such as ASIR, MBIR, and Sapphire. You can see the amount of noise less than that seen in the filtered back projection images. So, however, now they have been touted, these iterative reconstruction iterative reconstruction techniques have been touted in the literature as allowing much better image quality at lower doses than filtered back projection. However, in the maxillofacial region, numerous diagnostic and therapeutic tasks were tested using iterative reconstruction techniques and compared with traditional filtered back projection at ultra low doses. And with these tasks related to the maxillofacial bones and the paranasal sinuses, iterative reconstruction techniques did not show any improvements over filtered back projection. Now, the reason being that iterative reconstruction techniques provide improved contrast resolution. So they reduce the amount of noise, but they do not improve spatial resolution. And imaging of the maxillofacial bones, it does not require very high contrast resolution, but it does need high spatial resolution, especially when we want to see neurovascular canals. However, newer types of iterative reconstruction techniques called ultra high resolution iterative reconstruction techniques, they have reportedly improved both contrast and spatial resolution in imaging of the internal components of the petrous temporal bone for imaging of the inner ear. However, so they may have the potential to produce better images for use in the maxillofacial region. However, no studies that I am aware of have been published to date on maxillofacial diagnostic or therapeutic tasks using ultra-high resolution iterative reconstruction technique. So this is an area which is ripe for research if anybody is interested in doing such research. And finally, another factor which may affect the dose is the Mdct machine itself. Machines from different manufacturers may impart different doses, and even from the same manufacturer, newer generation of Mdct devices generally impart lower doses than older devices. And please remember that when we talk about dose optimization for any diagnostic or therapeutic task, it is using the lowest dose which will produce diagnostic images or images suitable for the therapeutic task. And the reference standard for determining the optimum dose is interpretation of images produced by various combination of scanning and reconstruction techniques to identify the ALADA protocol, which is the protocol which gives us images that are with as low a dose as diagnostically acceptable. Why do I emphasize that this is the reference standard for determining the optimum dose? The reason I am emphasizing this is because you will be exposed to so many published papers which will demonstrate images using different low dose and reconstruction techniques, and saying, oh, look at these beautiful images, we can see this, we can see that, but they do not compare them to a reference standard or a gold standard. So please be careful in this regard. And with that, we come to the end of our presentation where we discussed the basics of CT image production and display and the advantages and uses in the maxillofacial region and image quality and dose considerations in the maxillofacial regions. And I thank you for your attention. I will be taking the questions typed in the Q&A box now, but afterwards, if anybody has any questions or comments, you can contact me through this email. This is my personal email. I'm not posting the institutional email because it has a very strong firewall. So in this way, we can guarantee that I can receive your emails. Also, if anybody is interested for further reading, you can scan this barcode and you will obtain the list of the references that I used to compile this presentation. Thank you.
Thank you, Prof. Asma, for this lecture. And now we will proceed with the Q&A segment, starting with our panelist, Dr. Usama Al-Ghamdi, if you have any questions.
Thank you very much, actually, for your kind invitation and for the amazing lecture that we just had. If you may allow me for a few comments before, maybe not much of questions, but if you may allow me for a few comments on the talk we just heard. I would like to thank you, Prof. Asma, for the amazing, honestly, description and simplifying what we are using, in my perspective as a maxillofacial surgeon, what we are using in a daily practice. If you may allow me for 2 minutes to talk about just quickly what have Dr. or Prof. Asma have mentioned in our practice or clinical real life. Whatever she mentioned was about the detail and technology and the science, but I feel it and I touched it or touch me through the real practice of in our daily practice. Let's just quickly oversee the history of multi or Mdct. In the clinical practice, since the CTs were introduced early in the 80s, 1980s, where the single detector actually was used at that time, and how the difficulty to obtain a high resolution image over time. And also in that regard, we have learned the CT, whenever you want to image a soft tissue, the CT is not the proper way to go. Probably MRI is the only way or proper for soft tissue. Still that approach is still applied. However, it has changed significantly with introduction and actually improvement of Mdct. It has changed the way we look at it. So from the perspective of clinical, as I mentioned, the CT was not higher in soft tissue. Currently, or in our nowadays, CT, in fact, even for soft tissue masses in the head and neck area, it is the standard of care to start with. And if you have a further detail in the larynx, where all soft tissue and cartilage, probably you need to go with the MRI. Another big change in our practice in terms of using Mdct is the details in evaluating the traumatic or the trauma of the facial skeleton. And just to inform you that from our clinical perspective, in our ER, whenever we ask for a CT and they do the multi-Mdct, when they do it actually for the body, as Prof. Asma have mentioned, usually they go for low slices thicknesses, which results into low or inadequate exposure of the facial bones. With the evolution of the Mdct, it has changed the way we evaluate, and in fact we detail the facial bone fractures, so we can have a proper image and evaluation of the fracture site or traumatized site, so we can really detail even the management protocol. It is in fact the Mdct have changed the way we look at the areas, including the ethmoidal bone fracture, or what we call it NOE, or naso-orbital ethmoidal complex fractures, and it is now a standard of care. Our residents, whenever we get a CT, whenever we get a trauma patient consult in the ER, we immediately ask for an Mdct facial bone 1.5 thickness as a maximum to evaluate these areas. Another truly a big change, the utilization of such technique is the low radiation, because always the problem was with calling for MDCT is the radiation exposure. And as Prof. Asma'a had mentioned, how that is comparable with the multi-detector CT have that came to low as Cbct, and that allows us to actually not routinely order it. However, we can feel easy on us whenever we call for those scans to evaluate specific areas or problems in the facial or maxillofacial area. Probably from also clinical perspective, I think the main challenges that the main challenges that were not solved or helped by, which probably related to the technology itself with MDCT, is the availability of the MDCT. It is relatively available imaging modules. However, still it is hooked up to hubs in hospitals where you need a special booking system so we can get it through, and not like the availability of the Cbct. Another issue that we are challenged by is the artifacts, and I thank Prof. Asma'a for the details that she brought up with the artifact that we're facing. MDCT has not changed the way we look at artifacts, and it is not a superior module. You would look for it whenever you have amalgam restorations or a plating system, or even an orthodontics braces or wires in the mouth, that the artifact will still be high and still there. One of the points that I would like to also comment on our clinical practice is what Prof. Asma'a had mentioned about the spatial resolution, or when you go more thinner slices. And we used to have a standard to say go for 0.6 millimeter. However, that you get more noise and you cannot evaluate. So truly, just in summary, and this is the comment on the clinical perspective, how the MDCT have really changed the way we look at things. And I would comment more significantly on the pathology part whenever we have those patients in the clinic. Probably always, not always, we've been trained to look for MRI in a soft tissue, but truly MDCT with its reconstruction modules that Prof. Asma'a have mentioned have changed the way we look at it, because we know the CT is faster to get, is quicker and more efficient even, and cheaper and better and more convenient for the patient. So it is our first line request to call for whenever we have concerns about soft tissue masses in the head and neck areas. Another comment that I would like, and the last I would say, is about what have Prof. Asma'a mentioned about the reconstruction methods, or the way we do it is, I remember I got trained by one of pioneer actually radiology and CT scan in Canada, and he taught me actually, whenever you scan the patient, you need and you should always look first at the axial section, and that's where your diagnosis should come through and from, and you base through the axial sections, because everything else is a reconstruction. However, with the advent of the softwares, with the technology that had been implemented to MDCT, has changed also the way we look at it. So now, as Prof mentioned, that still the coronal and sagittal are not high resolution or better for evaluation as the axial. However, it is considered relatively considered diagnostic. So these are my comments that I wanted to put on how really MDCT have changed the way we look at it. I'd like again at the end to thank Prof. Asma'a for making this simple and easy. You know, I practice it almost on a weekly basis for our patients, but we never thought about the technology behind and how complex it is. And now I think it's more simple and make things even clear to us as a clinician in our practice. So thank you again.
Thank you very much, Dr. Osama.
Thank you, Dr. Osama. Always your clinical insight is fascinating. I'd just like to say something as a follow-up to what Dr. Osama said. It was interesting when Dr. Hughes mentioned about the slice thickness that you use for trauma cases. And this, I want to use that to highlight the different spatial resolution requirements that I was talking about related to the different diagnostic tasks. So for example, in a fracture case, the clinicians can view the fracture even with a slice thickness, I believe you said, doctor, of 1.5 centimeters. However, if
millimeter, correct.
Yes, sorry, 1.5 millimeters. However, if the CT examination was being done for implant site analysis, especially the mandible, we would need 0.6 millimeters, which is the minimum possible with many machines. And we would also decrease the pitch, so we will have even overlapping, so that the resultant voxel size will be so small that it's effectively, the slice thickness would be approximately 0.3, because we need to see the fine neurovascular bundles. So this just highlights the different spatial resolution requirements in the different maxillofacial diagnostic tasks. So thank you for that.
Oh, thank you too. Honestly, yeah. So, Prof. Asma'a, in that regard, when you change actually and you look for more specialists, are we increasing the radiation exposure? Do we, because of the increase of the rotations? Okay.
Yes, we are.
Okay.
But
and
again,
how significant is that? Yeah.
It really would depend on then the milliampere. So what we can do, depending on the characteristics of the machine itself and the noise that is produced by the machine, we may not need to increase the dose too much, but I really can't give you absolute numbers because you have to really test each machine on its own. Now, somebody's probably saying, okay, now you gave us all of these general information. How can we use it to determine the optimum doses for our machines, for our purposes? This is a very good question, and it's very difficult to do for every single machine. It's not feasible or practical to go and do a series of tests as we have done and other teams have done for specific devices and reconstruction techniques. So what we are doing right now in King Saud University, we are trying to make that simpler by developing an artificial intelligence model which can predict the ALADA dose for specific diagnostic tasks. We still haven't been able to obtain a model which it gives us the degree of accuracy that we wish, but we are working on that, and we are fairly confident that we will be able to achieve it. Once that is done, once an AI model can do that, then the manufacturers, whenever they produce a new device with new reconstruction techniques, then that can help them for that particular diagnostic task to just run the model and then tell the users, okay, this is the ALADA dose for this particular diagnostic task. And so we're fairly optimistic in this regard, but we still have a very long way to go. As end users, you have no control over the dose. So when I'm talking about the dose optimization, this is directed towards the radiology technologists and the physicians or dentists who are involved in the radiation departments in determining the exposure parameters.
Thank you, Prof. Asma. For the attendees who raised their hands, could you please type your questions and post them in the Q&A section? We have a question from Haytham and Ahmed. He's asking, can Cbct replace Mdct in dental applications?
Yes, thank you for that question. Cbct can definitely replace Mdct when visualizing teeth and bone. And as a matter of fact, for imaging of the teeth, Cbct is superior to Mdct because it allows the production of smaller voxel sizes, much smaller. However, for soft tissue imaging, Cbct is not useful. Mdct must be used. So let me give you an example of a case in which you would need both. Say, for example, you had a tumor within the jawbone. If you only need to see its extent within the jawbone, CBCT would be sufficient. However, if the tumor has grown beyond, expanded beyond the jawbone and has started to invade the soft tissues, then CBCT would not be enough. You would need MDCT with contrast and view it in soft tissue window to be able to see the extent of the tumor in the soft tissues.
Thank you, Prof. I haven't received any questions from the attendees that raised their hands. Dr. Noura Sufyan, if you have any comments or anything to add?
No, thank you. I really appreciate Prof. Asma for summarizing this topic in a great style, and I thank her for her time.
Thank you, Dr. Noura. I would like to repeat that there will not be any certificates of attendance provided for this lecture. لا يوجد أي شهادات حضور لهذه المحاضرة. And thank you to Professor Asma and to Dr. Osama and to everyone that joined and participated. If anyone is interested in following the announcements of our future activities, you may follow our Facebook page that is posted here, or you may reply to the post-webinar email that you will receive and ask to be added to the mailing list. Thank you again and see you at our next webinar, and good night.
Thank you, everyone.